to the second day of the conference. Let's begin with the morning workshop on endo hepatology. For the same, can I please invite Dr. Varun Mehta and Dr. Preetham Nath to please chair this session.
Very good morning to all of you. We'll be beginning with the first session, which is basically a workshop on endohepatology. Endohepatology is emerging as an important uh, offshoot in hepatology. Started basically as diagnostic and now going in more into the therapeutic field also, with varicose obliteration, measurement of the pressures. For this, we have some video sessions. We have two eminent speakers on that, Dr. Narinder Chaudhary and Dr. Arka De. Both of them are well known in this field. I'll first invite Dr. Narinder Chaudhary to start the proceedings with the session on endohepatology.
Thank you, Dr. Varun. Good morning, all. Slides are not moving. Okay, thanks. So we all know endoscopy can be sometimes difficult in gastric varices. We will start with gastric varices, then go on to liver biopsy and other procedures. Like in this actively bleeding gastric varix, it takes few seconds to our vision to get blood and it is difficult to glue endoscopically. There is lack of adequate visualization, maybe food residue or blood clot and fundus. Sometimes it is severe bleeding, we can't see anything. Of course, we cannot target perforator vessels and we cannot see if we have done good job endoscopically by glue because we don't have vision beyond gastric lumen. Coils. So look at this video. We use this nectar type of coil and there are fibrous strands attached to this coil, this metal body. So these fibrous strands, they help in platelet aggregation and blood clot formation. Coils are available for both 22 and 19G needle. It is easy to place by 19G needle. It is very difficult to place through 22G needle. Coil length is available as 2 to 20 millimeter. And we want to take a coil 1.2 times larger than diameter of varix. So for more than 2 centimeter gastric varices, coils are not good option. What fluid we should use? Because glue tend to precipitate with normal saline. So either 5D, 5D is better than 5D or distilled water better than normal saline. Procedure. After puncturing, so initially when we started this procedure, we used to aspirate blood to confirm that we are in varix, but there is problem when we aspirate blood because glue will precipitate in this needle unless we mix lipiodol. So we are bound to mix lipiodol if we are using aspiration to confirm our position. So we have punctured, we aspirated blood to confirm. Nowadays, I will not suggest that you aspirate to confirm unless you are not sure. Coil is there in this small device. We are pushing this coil. Once coil is inside needle, then we remove this divide and we use stylet that comes with FNA needle to push this coil inside varix. This is stylet. Okay. These are artifacts of coil. We remove this stylet then and then we inject glue. It is 1 is to 1, 1 ml glue and 1 ml lipiodol generally that is used. If we have not aspirated blood, we are sure, then I will suggest just inject glue, not mix with lipiodol, because lipiodol increases risk of embolization.
Dr. Narendra, it is an interactive session. Anyone can ask questions or make comments in between if the things are not clear. This is basically a bidirectional interactive session.
Another video, it is not my video, actively bleeding varix. Sometimes we can use perforators also. In case of single perforator, it is very easy. In case of multiple perforators, it becomes difficult. This is coil being placed. For larger varices, we can use multiple coils also. So we start with distal part of varix and to place first coil, then we come to proximal part. It can be EUS guided glue, coil and glue. Combination results are better. Coil and glue are better than glue alone or coil alone. But for smaller varices, I will suggest to go with coil and glue alone rather than a combination. Combination is not mandatory for every varix. 55-year-old male, recurrent bleeding, CLD, portal hypertension, HCC, PVTT also. So because of PVTT, not a candidate of TIPS. Large fundal varix, endoscopic glue done twice, but again there was recurrent bleed. CT shows a large tumor in right lobe of liver and portal vein tumor thrombosis, and this is endoscopic picture. Large varix, it explains why endoscopic glue keeps failing repeatedly in some cases. Already two prior procedures of endoscopic glue. Still, this is soft to touch. EUS image. So this thing here is prior glue. Yeah, this one is prior glue. It shows stone-like artifact. We measure diameter of varix at short axis. Then we take 1.2 time larger coil. We have punctured varix with needle. We are aspirating blood. So nowadays, as I said, don't aspirate blood. It keeps thing complex. Coil is inside this short device. We place coil inside FNA needle by stylet. Then we will remove this device and we will keep pushing by stylet of FNA needle. Initially, we used fluoro in such cases. Nowadays, we don't use fluoro. This is okay. So we can say coil artifacts here. We remove stylet. This is another coil because it was a big varix. First, we placed a coil in distal part, then we are placing a coil in proximal part. This is second coil in fluoroscopy view. Glue being injected, and after glue, we flush with 5D. This is glue mixed with lipiodol, so we can see in fluoro, and we can see a good obliteration of varix and markedly decreased flow. If we are not able to puncture varix from fundus, we can puncture it from lower esophagus also. Protect eyes is very important. Once we injected glue, then we push sheath a little bit. Ideally, we withdraw everything. Our technicians are very confident that this needle channel will not get blocked. If the Arakawa classification is useful in deciding which varix to go with EUS guided therapy. So if there is single perforator, it becomes very easy. If there are multiple perforators, then it becomes difficult. If there are multiple channels, then again it becomes completely obliterated by EUS guided therapy unless we target a feeder. If we can target a feeder, less coil or glue is required, so less adverse events, less embolization, and fewer sessions are needed. Visualization of feeder is important, and in presence of multiple feeders, it becomes difficult. If you are targeting a feeder, I suggest to sit with radiologists to understand afferent and efferents. Sometimes in large gastric varices, there is a issue that the vessel we are looking is gastric varix or it is a feeder outside gastric lumen. So layer 4 of stomach becomes very important in such cases. If we can identify layer 4 is hypoechoic, it is muscularis propria. If we can identify layer 4, then we are sure that we are looking outside stomach. Again, to show, so this is gastric varix, and here we can see layer 4 and then it becomes a feeder. It is not part of gastric varix. Large gastric varix. So this varix measured more than 2 centimeter at short axis. So we try to sorry.
Dr. Narendra, if the vessel is outside the stomach, as you was showing in the previous slide,
Yeah.
what do you suggest? Should we go ahead with the US endotherapy or not?
If not multiple feeders, so sometimes gastric varices have multiple afferents and multiple efferents also. So yes, we can go definitely. It is same as we do for gastric varices, but I will suggest you discuss with radiologist to understand anatomy.
Thank you.
So this patient had more than 2 centimeter size gastric varix. Oh, sorry. ये pause कैसे होगा? So here it is gastric varix and this is outside of stomach wall. So this is feeder for this gastric varix. This feeder, you can see your position by pushing saline also. I restart this video. So this is saline being injected. It creates bubble inside vessel. These are coil artifacts. So glue was injected after coil. This is post glue, good obliteration of shunt. And when we look at gastric varix, so it stops blood flow in gastric varix immediately and there will be thrombosis. We can see this is intraluminal part of gastric varix and now there is almost no flow in this gastric varix. It happens even in 1 minute. So it was after 40 seconds. A large gastric varix, we chose feeder to inject and no flow in gastric varix. This is this feeder embolization endoscopy at 6 months and 12 months. This gastric varix is gone. Sometimes gastric varices are difficult to puncture. Our orientation is different than most of persons what we do. So this needle comes from left to right rather than right to left. So we are not able to puncture this varix on left side despite multiple punctures. So take a new needle in such cases, it helps. Another example of rectal varix. Again, we are not able to puncture. So if you are not sure that you are inside, then only I suggest to aspirate blood. Otherwise, don't aspirate blood and use undiluted glue without lipiodol. So what can go wrong in these procedures? We can see very little water. So I am not able to puncture, and by a jab, this needle punctures gastric varix and also it crosses gastric wall, it reaches up to stomach. Look at again. I am not able to puncture, I forced and it touched spleen. And it started bleeding inside lumen because I punctured this gastric varix from both sides. So these bubbles indicate bleeding. So have adequate water before we puncture. It was mistake to not have adequate water. It was obese patient. I feared for aspiration, but this is endoscopy of this same patient. It showed some blood in fundus. Fortunately, not much. We could complete procedure within 1 minute, coil and glue. Size of coil. Again, it is not my video. You look here. This is a smaller coil. It is very old video. I don't know who made it, but this coil is definitely smaller than size of varix, and it got embolized to lungs. When not to do EUS guided therapies, so when gastric varix is more than 2 centimeter, when there are multiple channels, we are not sure if we can obliterate it completely. Again, whenever you don't have diameters, this is EUS scope 15 millimeter, 14 point something. So it is more than 2 centimeter varix, and this patient was referred for BRTO, IR guided therapies. This patient feeder is also very large. So now we are looking outside stomach. So gastric varix is also very large and feeder is also more than 2 centimeter. So not taken for EUS guided procedure. Adverse events, these white bright spots are glue embolization to lungs. Again, we can see glue embolization here. My cursor is there. We have seen this video. We targeted feeder in this patient, and because we can see coil in feeder, because we were not sure, we aspirated blood, we had to use lipiodol, and you see lipiodol is going to lungs. It is going up also and down also. It is going up and it is going down also. So this patient has pulmonary embolization. We had several pulmonary embolization. Fortunately, it remains asymptomatic. And this coil glue and lipiodol goes lower side also. Then we got a CT and it showed linorenal shunt. It got obliterated. I showed this video earlier. Needle is reaching up to spleen. Sometimes when position is very difficult, we are not able to place complete coil inside a varix. It is fine. If partial coil is also there, it is fine. This is December 2022, August 2023. So although it was partial deployment of coil, it is fine. No varix in follow-up. How to avoid adverse events? No lipiodol and do not aspirate blood to confirm. Proper size of coil. Glue is not mandatory. If it is a small varix, coil alone is enough. You take a new needle if it is possible, and proper visualization have adequate water. Ectopic varices, 66-year-old male, decompensated cryptogenic CLD and malignancy, CTPC, not a candidate for tumor therapies, SBP, AKI, everything. And this is PR bleed. We can say large rectal varix with active bleed. EUS view of this rectal varix. Needle is inside. Coil is being placed, followed by glue. This is post-procedure image. This whole of varix got solidified. 63-year-old male, cryptogenic cirrhosis, child C, jaundice, ascites, HE, melena. When we do endoscopy, it is necessary that we go as deep as inside, because this patient had EVL twice before it was diagnosed that it is duodenal ectopic varix bleed. So this was in at D2, D3 junction. We can see active bleeding is going on. Endoscopic glue. Despite glue, it keeps bleeding. Sometimes feeder vessels are very large. Glue doesn't stay in this varix. So ectopic varix or gastric varices may keep bleeding. This is EUS image. Coil is being placed. It was a difficult location, so coil was only partly placed. Part of coil is outside, and due to difficult location, we could not inject glue. So this is endoscopic glue. Coil is by EUS, and this is endoscopic glue. This time glue stays in varix because coil keeps glue there. It was in difficult location, so only part of coil was placed. Part is inside, part is outside. This is post-procedure image. 33-year-old male, EHPVO, we can see bleed from here. We can visualize on EUS and coil is placed. As I said, sometimes these patients have large collaterals, so glue doesn't stay inside varix, but EUS, because coil is placed, it helps in decreasing embolization, it helps in keeping glue there, but embolization is not zero with EUS guided coil and glue. It is less than endoscopic glue, but it is not zero. 52-year-old male, post LDLT, portal vein thrombosis. So these patients behave like EHPO with portal hypertension. Esophagus okay, stomach okay, D1, D2 smeared with blood. We can see some abnormality here. It is actually ectopic varix in duodenal bulb. We can see flow in this varix. Again, coil, glue, no flow in varix after coil and glue. This is pre-procedure image. This is after 6 months. This varix is completely disappeared now. I stop here. Any questions?
Please.
Myself, Dr. Pratap Molli.
Yeah.
If cost is not an issue, between 035 and 018, is there a preference?
Actually, EUS guided procedures are cheaper than IR guided procedures. So large varices endoscopy is poor choice, we all know. EUS guided BRTO at our hospital, it takes
So,
2.5 to 3 lakh.
can I
Sorry,
interrupt? Between O35 and O18 coils, I'm asking.
I will go with bigger coils. So that can,
O35.
yeah.
So when deploying O35, if you have a difficulty in removing the coil outside, apart from straightening the scope a little bit, and even the diurnal varix you have shown,
Yeah.
it's a big loop. Anytime did you need to sacrifice the needle because you couldn't take the coil out? I had a couple of cases where the coil got stuck, O35 coil got stuck in the needle, and I had to sacrifice the needle.
Deploy the coil outside.
So before placement, we make ensure that we are in a relaxed position. Coil deployment is easy. We have tried a smaller coil also through 22G needle. It is very difficult. So it is easier through 19G rather than through 22G. So I would go with bigger coils.
Okay.
Even if a coil is partially inside, partially outside, it is fine. I showed here two examples. It is fine. That's okay.
So when doing these procedures, if your practice is to do all these cases under GA,
Propofol.
no, if in our center we do under GA, but obviously ours is a less volume center compared to yours. Does the risk of post-procedural complications increase with GA in these cases, whatever the child status?
So you intubate and then do procedure.
Yeah.
Short
Because
term
I don't know the other way of doing it, so
Okay, so
just curious to know.
we don't intubate, but patient remains under propofol sedation. Propofol has very short life, few minutes only. So I will suggest to go with propofol. I don't think short GA will change anything, but propofol is we haven't none of case we needed GA. It is done always under propofol and it is okay.
Thank you.
I think I agree. We have never done under GA, and in fact, your GA could be risky. These would all be liver disease patients.
Can I add on here that, but there should be a presence of an anesthetic team along. The support system has to be there. Yes.
No, they may not come out. See, when you're in a small volume center, then the chances of an adverse event occurring goes up the more you do it, right? So I mean, the statistics don't really apply like that. In general, GA is not recommended in CTPC. That's why you give a very high surgical clearances to them also. So I think the procedure should be done under propofol, and I mean, in the presence of an anesthetist, obviously. The thing about the coil not getting deployed in the 018 versus the 035, I don't think the 018 thing, since we deploy it to the 22G, is very difficult to push out of the needle. That's the, but when you are not able to actually deploy the coil inside the varix, that's got less to do with the gauge of the individual. So it's like this. So it's to do with the individual thread, what is that size, as opposed to the actual diameter of the coil. The coil has a length and it's got a diameter, right? So the diameter decides what is the number of coils maybe you need to put, because that will correlate with the size of the varix. But then sometimes the length of the coil also comes into it. It's either, I think, 200 or something, and it's a 1/4. So the smaller length is easier to push out of the scope. But if you're not able to push out of the scope, it doesn't really matter. Like he said, it
If
very commonly
so,
occurs
sometimes
actually
we
with
use artery forceps to push it.
push it out.
So if
Yes,
you are not able to push it by thumb, use artery and then push it.
so the technician has to be very good. If you're not able to push it out, he has to catch it with the artery forceps, get it out. You can maneuver your needle a little bit, open up the elevator, open up the, if you're doing it in a lock position, you can unlock it, get into more relaxed. Later you're able to push out most coils. But sometimes what happens is when you're doing rectal varices, duodenal varices, these are the times when there is not enough length, and sometimes, and I think those are the times we face more problems. I think Dr. Narendra, one of the things that these people have sometimes doubt about, do we do it from the esophagus or from the stomach? And if we're doing from the esophagus, how to, the crude of the diaphragm or whatever the other things that we need to be careful about. I think so you can just highlight that one.
I prefer from stomach. I haven't done from esophagus.
Experience.
Literature says, but I and we at Medanta, I don't think we did any from esophagus.
So that's also, I think, our experience. I think the literature would say if we puncture from the esophagus, maybe the esophagus itself constricting would help somehow or other. But it becomes more difficult because practically all our patients do have esophageal varices. And because you're in a compressed state, sometimes those varices might get compressed by your US probe. You have done everything perfectly, and then you see that there is a US. So we prefer to do it from the stomach. But the only thing that I think whatever procedure we are doing for the gastric bypass, that depends on what setup we have, what we are working in, because the evidence of vis-a-vis comparisons is kind of limited, particularly with this US and BRTO. So the 2 centimeter varix, we don't go above that. That I don't think that we believe a lot, because like you said, that BRTO is a lot costlier. So in PAGI also BRTO is costlier, because simply the IR guided instruments, the accessories are costlier from us. So we do gastric varices at a much larger size. So we can always combine the coils, and as long as the coil diameter is roughly about the whole variceal size, that's okay. So I think in our experience, the average size would be around 3.1, 3.2 centimeters. And that has not really correlated. The variceal size has not correlated with outcomes. And here, because see, when it's embolizing out, it's going to embolize out of the efferent. So we are trying to fill up the whole varix. So long as the coil diameter is larger than the size of the efferents, it's not going to embolize. So the actual variceal diameter size may not matter. But of course, if you have got BRTO and etc., we should
That's very true.
balance the thing and do it.
So I had one doubt regarding ectopic varices. I'm Ayush, sir.
Yeah.
For example, in duodenal varices and rectal varices, where we think that the size of the varix is small and the coil may not completely deploy. Sir, is the role of deploying coil in the first place? Because
No,
maybe
no,
the
no.
glue may
No,
be
it is
enough in
not
this.
mandatory. So coil followed by glue is not mandatory. It can be coil alone, it can be glue alone, it can be combination.
Then, sir, how do you decide in such cases whether you want to deploy a coil or not?
A small varix don't go with coil, just glue.
So, like in ectopic
Undiluted
varices,
glue is better than diluted glue.
okay, sir. And any combination you use with glue in your practice in which the chances of embolization are less? For example, if you're not using coil per se, like there was recently a paper from AJG, published in AJG, that said that if you apply a clip over the afferent and efferent feeders, particularly in cases where there's a large ER shunt, in which you suspect that the embolization chances are higher, they they showed that the chances of embolization become less. I'm not really sure ectopic varices may the
I'm
feeders are
also
not there,
not
but
sure. Never tried.
so not combining glue with anything.
Applying clips is, I don't know how.
Endoscopic, yeah.
No.
That is true. Sir. Just a bit.
So, when you have a chance to do both, the feeder embolization versus an intragastric glue or coil, which one do you prefer?
If you can identify feeder very well, single feeder, then feeder is better.
So, sir, my doubt
Because
is,
feeder will require less amount of glue or coil or less number of coils. Feeder is better.
sir, but theoretically, the feeder is a part of the varix where the diameter is the least. So, the flow will be 4 times directly proportional to the diameter. So, which area would you prefer? Will it be at the site of the perforator or at the site
Smallest
of the
area,
smallest area? So, the feeder.
narrowest diameter.
But the issue is that finding whether it is an efferent or
That is
afferent.
very difficult. So in one of the patient, we had embolization on both sides, toward lungs also, towards glenorenal shunt also. So if you want to target feeder, you discuss with your radiologist what are afferents or efferents. In US also we can find it, but it is really difficult.
And sir, that formula you gave for for making a sense of the size of the coil to be deployed
1.2 times of the smallest diameter.
So that gives a diameter part.
Yeah.
How is the length determined?
Length is, it's okay.
Doesn't matter.
No, no.
Okay. Thank you, sir.
More length, it will become more difficult to deploy.
Yeah. So the length doesn't matter with respect to the variceal site. So there's a lot of thing about trying to target the perforator with this gastric varix. In our experience, what we have found is that trying to trace the perforator out from the shunt site, is it coming from the LGV, from the short gastric vein, etc., that kind of becomes more difficult. The easiest way out is you first locate the gastric varix, and after that, if we do clockwise, we will tend to go towards the afferent, and the afferent will come out somewhere from the 5 o'clock, 4 o'clock, that kind of an area. And if we keep doing anti-clockwise, then we will reach the perforator, the afferent. We will reach the afferent, and that will be somewhere around maybe around 11 o'clock, 10 o'clock-ish, like this area. But let me be very clear, this is advanced hepatology. So advanced endohepatology, you have to do it a lot with your radiologist to get confidence that I am actually arriving in that area. You might have to like continue the movement and go on there. So do not target the perforators initially, at least till you have got sufficient experience, obliterating the actual gastric varix. That's an easy procedure. Doing it in perforator and etc., that's mainly, actually we do it mainly when the patient is not affording. A bleeder has come to you and the patient is not affording for the coil. Then sometimes we end up going and doing it. But it's such a simple procedure becomes I think, a much more complicated and a longer procedure when you're trying to find out the perforators. So don't try it.
I'll second the thought of Dr. Arkade that if you're beginning, you should target the fundal varices. You fill the lumen with a lot of water, and those varices which are actually bulging into and floating in the water, you should target those varices, as Dr. Narendra was also saying, that you need to identify the layer of the stomach and target those varices first if you're to begin with the endotherapy for the gastric varices.
Regarding the clip, there was only one published paper that using the clips can reduce the risk of embolization. But in endoscopy view, it will be very difficult to know which is the apparent, which is the efferent by only the gastroscopy view.
If you don't make slipiodol, embolization is anyway less. So it happens mainly with lipiodol.
I think one thing Dr. Narendra, which Narendra said is important is in classical teaching, but people say that the risk of embolization with EUS is very negligible, but that is not true. It does happen in EUS glue therapy. So we need to be careful.
Sir, here one question, sir. Like in case of in emergency active bleed from the gastric varices, is there a first line management we can plan from US guided coil as a first line management?
Yes, of course. So if
Okay.
there is a clot you are not able to visualize properly, US becomes first line. It is easier to do with the US rather than endoscopy.
Okay. And second is like how you confirm like sir obliteration is complete
No
by
flow in
sir,
varix. So that
Doppler
is
Doppler alone is
Doppler.
sufficient.
Yes, yes, doc. So it will take some time. It doesn't happen in few seconds, okay? But in 30 seconds, 1 minute, you will see obliteration of flow.
Okay. Thank you.
This is advantage of US that you can see obliteration of flow in real time.
Okay. Thank you, sir.
You can.
Thank you, Dr. Narendra Chaudhary. You can join us over the dais. Next, I'd like to invite Dr. Arkade for the next talk. Arkade doesn't need any introduction in this forum. He is a faculty from PGI Chandigarh.
Give the next PPT, please.
Over to you, Dr. Arkade.
The other PPT. So we actually had other videos, I think, Dr. Narendra, but we will go back to them if we have time. So this is quickly a case, this is basically a case of chronic kidney disease and stage renal disease on maintenance hemodialysis. And he was referred to us from the nephrology side to take a decision on renal transplant alone versus simultaneous liver kidney transplant, as he has got significant alcohol intake and is also a known diabetic. His investigations showed thrombocytopenia, AST being more than ALT, along with hypoalbuminemia, which are features suggestive of maybe some underlying advanced liver disease. And however, the ultrasound showed that the liver had regular margins. There was discrepancy in that the LSM was 28.6, the post-dialysis LSM, which actually tells you that the patient has clinically significant portal hypertension. But the splenic stiffness was not suggestive of clinically significant portal hypertension. And the decision in these kind of scenarios where they want to do a simultaneous liver kidney transplant or a renal transplant alone actually depends on whether there is clinically significant portal hypertension. So the decision was taken to use endoscopy as a one-stop assessment of liver disease and portal hypertension. So first, an endoscopy is done. If varices are present, automatically CSPH is present. But then there was no varices in this patient, and therefore the decision was taken to do both liver biopsy and PPG. So what do we look at before we go ahead with liver biopsy? First and foremost, the indication should be cleared that do we at all need a biopsy or not, and then the contraindications. Over here, the controversial, I think the main contraindication is there's a large ascites, which is separating the liver from the stomach wall. That becomes an obvious contraindication. But the controversial part is what amount of coagulopathy can you tolerate? In general, we do it, we don't do if the platelets are less than 50 or if the INR is more than 1.5. But prior to a procedure, we do a sonoclot or a ROTEM to decide on a transfusion if required later on. The pathologist must be in the loop. It is very important that the histopathologist be experienced in, be comfortable in reporting US liver biopsies, because these will be 19G biopsies. So the biopsy core length might be adequate, but it's going to be thinner as compared to your standard percutaneous biopsies, which are 16G. So the pathologist must be comfortable with that. Which needle to use? The literature says that the Franzen tip US FNB needle, that is basically the acquired needle, that is the one that is to be used. And also the literature says that the FNB needle, the diagnostic yield is higher than FNA needles. However, again, because of the cost issues, we do use US FNA needles, 19G FNA needles quite a bit. And in our experience, what you find is that unless the patient has cirrhosis or very advanced fibrosis, the amount of tissue that you get, even with the US 19G FNA needle, is usually sufficient, particularly if you're using the wet suction technique. So various techniques have been described, but of them, the wet suction technique, the modified wet suction technique, this is what is currently used by most people. And the needle is pre-flushed with heparinized saline. This prevents clot formation in the needle and may lead to less fragmentation. As the tissue that is coming into the needle, there will be less contact with the walls of the needle. So this is the way, the needle is first pre-flushed with hep saline, and then this is the way the suction syringe is prepared. The vacuum inside the syringe is prepared. You pull in around 5 ml of saline, and then the suction is applied, and then the stopcock is rotated to maintain the suction. How does this move forward? So the basic technique is you localize an avascular path in the liver from the stomach if you're targeting the left lobe. That's the usual target. Usually you target segment 2, 3. But any part of the liver can be targeted. Anything that is avascular and has got adequate liver volume in that area can be targeted. Particularly in cirrhotic livers, the left lobe is atrophied, the caudate lobe may be very enlarged. You can target the caudate lobe, but very sure that the caudate lobe vessel is not there. You can target the right lobe from D1. So whatever is avascular, you can target that. Now, when we are puncturing it, the first push should be a little jab, because the stomach wall can be thick, so you will have to penetrate it. So sometimes what we see our residents doing is, very slowly they push the needle. What that happens is it pushes the whole stomach wall away. So the first puncture has to be a little forceful jab to get through the stomach wall and into the liver. Now, once we enter the liver parenchyma, we open the stopcock and turn on the suction, and then we usually take 3 actuations of the needle. There's a lot of debate how many actuations do you need. Now, you don't need to excavate the whole liver. You just need sufficient liver tissue for the pathologist to give you a diagnosis. And we find that usually 3 actuations is good enough for that. How much of a throw do you need? That depends upon what is the liver length. So we tend to do more of US liver biopsies in cirrhotic patients, because that is the part where your percutaneous liver biopsies, etc., becomes difficult. So that is why we choose these groups more. And there again, we may not have too much of a path. So, but if you have a 3-4 centimeters path, that is good enough. If it allows, you can take a longer pass also. Before we remove the needle from the liver, always turn off the suction by turning the stopcock. Otherwise, what happens is you withdraw the needle, some of the stomach material and the stomach mucosal content can also come in and contaminate your tissue. Now, one of the things that we have learned is that after we have removed the needle from the scope, now when we are removing the suction syringe from the needle, if we first turn off the suction and turn off the vacuum before opening the stopcock, that reduces the fragmentation rates. So release the negative pressure of the suction syringe prior to opening the stopcock. Okay, this is for, again, sometimes with beginners, what happens is you should be able to identify what is the liver and what is the spleen very easily by looking at the vasculature. But sometimes what happens is that the spleen is very, very enlarged, and you are doing anti-clockwise, looking at the left lobe of the liver, and you end up in something that looks bigger. That is actually the spleen. And this has been reported in the literature that while doing liver biopsy, mistakenly a splenic biopsy has been taken. So the trick, obviously the vascularity gives you a clue, but the other trick is Here, as we are doing anti-clockwise, see, this is the liver because it's coming from the right-hand side of the screen. The structure is coming from the left-hand side of the screen. That would then be the spleen. So please make sure you don't inadvertently end up doing a splenic puncture. Okay. So to do the liver biopsy, you locate the left lobe of the liver and find an avascular path, measure, freeze the image, measure that what is the proximate length of the needle throw that you might have, and you see the initial pass of the needle into the liver is a quick jab. It's punctured into the liver. And then we take 2 to 3 actuations. So very frankly, when they say ki ultrasound guided percutaneous needle biopsy, it is not really completely 100% real time. When you're doing the actual actuations, you do lose control. But over here, this becomes real time. Now, while withdrawing the needle from the liver, I'm so sorry it went back. While withdrawing the needle from the liver, that should be a slow pull because you're looking to see is a Doppler signal becoming persistent out there or not. And if a Doppler signal is there, it's best to just withhold. So I'll just put this forward. So you can see just before we withhold, we withdraw the needle, we apply the Doppler signal to see if a needle tract is forming or not. So there you see, we apply the Doppler signal, there is no needle tract, and so then we will withdraw back the needle. So the first jab is a quick jab, and the final pullback is a slow pullback to see if any Doppler tract is forming or not. What if there is a persistent Doppler signal in the needle tract? First and foremost, do not panic. Keep maintaining pressure with the transducer. Usually the liver parenchyma itself will tamponade the bleed. And keep observing with power Doppler, either a power Doppler or H-flow Doppler. Keep observing with that if the signal is persisting or not, and most tracts will settle down on its own. If it is persistent, then what can you do? One is you can sacrifice the tissue. So if your needle is still inside the tract, you can push out a little bit of the tissue into the tract and then hope that the bleed settles down, but then your tissue is lost. This is something that we have never done. Other option is, which has now been reported in the literature, is to inject gel foam into the tract. We have previously injected glue, and the last resort would be IR help. So this is a video of the gel foam being injected. So here you can see this is the persistent needle tract, and which persisted despite sacrificing the tissue. And this the tract is exactly punctured roundabout with the needle, and the gel foam slurry is injected. And as you pull it back, the gel foam slurry keeps getting injected till it also goes into the subcapsular area. And I really think that that is what is maybe stopping the bleed or whatever, but at least the patients do not continue to bleed after that. As you see, as the needle is getting pulled back, further slurry is getting injected, and the slurry also goes into the subcapsular space and hopefully seals up the capsule as well. But still, this is a very, if the Doppler tract does persist after your, despite application of pressure and sacrificing the tissue, I think go give a quick call to the IR. That's what's going to save you. This part is very, very important, that after we have taken the biopsy, how to handle the tissue. We must minimize tissue handling to prevent fragmentation. Now, initially, we used to directly push out the tissue into formalin. That resulted in very, very bloody samples. In the West, the collection sieve is present, which they can just peel off and take it. But this is the collection sieve, the micro sieve with the removable mesh. But this is not available in India. So in India, what we do is that, so what the technique that we do is we express out. Here we are putting it from the specican, but nowadays directly from the needle, we push it out, express it out onto this sieve. This is a mesh-like sieve. It's a industrial sieve, not channi for for doing atta wala thing. But this is an industrial sieve with very small sizes, and we directly express it out from the needle onto this mesh. And what this allows is that the blood components and just minimal flushing with heparinized saline, that just allows all the blood to get automatically separated out, and you're left with pristine tissue like this, which can then, you can just rotate the mesh over the specican and flush out the tissue onto that. So we have found this to be very, very convenient and cheap and easy. And this is the tissues that you can obtain even in cirrhotic patients. So usually we observe the patients for 1 to 2 hours. Even if bilobar biopsies are taken, I don't think that changes any of the adverse effect outcomes. But some amount of mild pain can occur in 1/3 of the patients. That's what is described in literature. But it is very mild, and we don't see that too often in our practice. Even if the pain occurs, it's self-limited. But of course, if there's persistent or severe pain, then you should admit and get a CT. Now, moving on to portal pressure gradient assessment, because this was the second plan in this patient. And there is now more and more emerging data that there is good correlation between portal pressure gradient and hepatic venous pressure gradient. However, the data is limited. And mind you, it's not a perfect correlation. R equal to 0.82 is still not a perfect correlation. So there wouldn't be a 1:1 correlation, and we need more data on that. But how do we do it? The technical details. In the West, we have got this proprietary manometry device. It's directly attached to the needle, but this is not available in India. So we use this modified setup. So this setup is similar for measuring like the intra-arterial BP or the central venous pressure with the pressure monitoring module. So this is the cartoon of the setup that we have. So this is the pressure transducer. The needle is connected with the pressure transducer using non-compressible tubing, and the pressure transducer is again connected via non-compressible tubing to a multi-parametric cardiac monitor, and the other channel of the pressure transducer goes on to the heparinized saline. Now this is obviously an adjustable pole stand, and your table is also adjustable. So they should be adjusted such that roughly the pressure transducer is at the mid-axillary level of the patient. I said again, roughly. It does not have to be very, very, very exact like it's been described in some of the papers which have used laser pointers and laser markers to exactly maintain level. And why is that? That is because if you are not level, then your absolute pressures will get affected. But here we are interested in the pressure gradient. So since we are subtracting, that change will get cancelled out. So you don't need perfect leveling, but yes, it should be more or less level. What will happen if, say, the bed is here and your pressure transducer is here? Your pressures will come negative. What will happen if your bed is here, pressure transducer is here? Your pressures will come very, very positive. It will go out of range of your monitor. So keep them more or less level, and then just go ahead. You cannot keep them very far away from each other. So leveling is desirable, but slight discrepancies will not affect the gradient. We validate the procedure prior to each procedure. You must validate the setup prior to each procedure preferably. And why is that? Because we are using a non-compressible tubing, but that gets kinked with time. You're not using in every patient. It gets kinked with time. Another thing sometimes happens that the needles can be bent, etc. So validate the thing. And how do we validate it? So this is the formula. Basically, the pressure transducer and this glass is again at roughly the similar level. This pressure transducer should be a little lower. So they should be roughly at the similar level. And then you need a cylinder. This cylinder, you will have to, spend some energy on making it. So basically, it's a flat-bottomed cylinder. And most cylinders on the side are marked in ml. But you will have to get it marked in centimeters. So you can do it using a scale and permanent marker and mark it up yourself. But just ensure that the cylinder at the bottom is not concave like this. It has to be flat. It doesn't matter if it is very thick flat. So say this is the cylinder and it is this thick flat. Then you will take a 0 from here. So you mark up the centimeters. And so in the first case, let's say there is AW centimeters of water in the cylinder. Then, and your corresponding pressure that you're getting on the monitor is AM millimeters. Then you change the water level to say BW and you get a corresponding reading BM. So the formula should be AW minus BW is equal to AM minus BM. AW minus BW centimeters of water is equal to AM minus BM millimeters of mercury. I am so sorry. Into 1.36. This is the formula. So the formula is AW minus BW centimeters of water is equal to AM minus BM millimeters of mercury. Why is this? Because mercury is 13.6 times denser than water. So why 1.36? Because this side it is centimeters and this side it is millimeters of mercury. So if you go back to your physics days, pressure is equal to density into height into gravity. So remember, you used to read rho 1 h1 g1 is equal to rho 2 h2 g2. This is basically that same formula. What sedation do we use? Your choice of sedative should be such that if it affects hemodynamics, its effect on the systemic and portal hemodynamics should be same. You cannot use an anesthetic agent that has got differential effects on your systemic or your portal hemodynamics. That is why in these scenarios we generally tend to avoid propofol, because it has got a larger effect on your systemic hemodynamics and your portal hemodynamics. And generally we use either low dose midazolam or fentanyl in these patients, similar to what the radiologists use when they are measuring HVPG. So the basic steps, we usually use a 25G needle, but you can also use a 22G needle if it is not available. The entry site of the vessel should be surrounded by adequate liver parenchyma. So what's stopping the vessel from keeping on bleeding after you're puncturing? One is that your needle size is very small, and second is it is surrounded by adequate tissue to tamponade the entry site. The needle, for measurement of the systemic venous pressure, you will pass your needle into the hepatic vein, or you can also puncture the IVC. Personally, I find that puncturing the IVC is usually much easier and more convenient most of the time, because it's that big chordate lobe sitting out there. Then you flush with heparin saline, record the pressure. First readings are often erroneous. Reflush the needle and then take 3 other readings, and the average of the 3 readings is taken. Needle is withdrawn and then it is pushed into the portal vein. Usually we push it into the umbilicated part of the left portal vein, but again you can also put it into the main portal vein if provided there is enough liver tissue from the angle that you are approaching it. And your portal pressure gradient will be portal venous pressure minus the hepatic vein or the IVC pressure. So that's the IVC. That was the right hepatic vein which went by, I think. Okay. So this is the hepatic vein. This is the middle hepatic vein possibly. So usually we target the middle hepatic vein. If push comes to shove, you can target the left hepatic vein, but your entry point will really be a little too perpendicular. So it's better to go into the middle hepatic vein, and then you will take your 3 pressure readings. You flush it, take the pressure reading, flush, take pressure reading, like that. And again, I will show that to you how we do it in our setup. So the portal pressure, again, you can just... So this is the umbilicated part of the left portal vein. You have to be careful. There could be a vessel on the top side. Identify that and don't puncture that. And you enter into the portal vein and then you take your readings. Now for the beginner, if you are having doubt as to what is the vessel, you can always use pulse wave Doppler. But frankly speaking, if you are having to use pulse wave Doppler to identify the vessel, then this is too early a stage for you to be performing any of these interventions. Okay, so this is the way we do it. So initially you can see that the syringe is attached to the pressure transducer and the stopcock, just like we do for CVP pressure measurement. Then the syringe is going to be... Now what we do is we puncture the vessel. Once the vessel is punctured, the syringe is taken out from the setup, so it is open to air. And once then you open that to air, you set the 0 on the monitor. Zero is set, syringe is reattached, and then you close it to air, open it to the patient, and you flush it. Now look what will happen to the monitor as soon as Arpit flushes this. Can you see that this was the time when he had flushed it, and this is what happens. So you will get a sudden rise in the pressure reading, and then it will begin to fall. Don't get alarmed if after flushing the pressure reading goes down and then keeps getting up. This just depends on whether your table is higher than the level of the pressure transducer or it is below that. That way it will depend on which way that curve is going. Now allow the curve to settle down. So after this, your next step would be on the monitor, you optimize the scale. Otherwise, this pressure tracing will go very much down. So we optimize the scale such that the tracing remains in the middle, and you will be able to see the waves and it's settling down into a straight line and then maintaining. Usually we take at least one complete tracing of maintenance before they think of it as we take that reading, and take at least 3 concordant readings. So in our patient, for instance, the patient had F4 fibrosis and he had 6 millimeters of mercury as this portal pressure gradient, and therefore he was cleared for renal transplant without any complications. So I think I will stop here, and if there are any questions regarding liver biopsy and PPG. Is there anything that you do different for liver biopsy?
Usually the same. But usually we avoid the right lobe of the liver. You usually do it from
I would say practically we never do it from there. It's always from the
Left lobe always.
Left.
Sir,
Doesn't make
what's
sense.
the heparin dilution that you're taking for priming the needle?
That's a standard 1:50,000. The same heparin INASL. What do you want? 50,000.
So technician meets is honestly I not asked. So
And
every
is it-
time
It's a
is same,
standard
but-
hepsaline that is used for everything of that.
And is it usual practice to prime the needle for pancreatic biopsy and everything, or just liver biopsy you do that?
Once again,
Is it standard practice for every biopsy or just liver
we
biopsy?
prime for every biopsy.
Just for liver biopsy.
It is
For
standard
other
for-
biopsies we don't heparinize.
But wet suction is always better than dry suction for all the US guided sampling. Whether it is a mediastinal lymph node, whether it is a pancreatic tissue which you are looking at, a wet suction technique is always better than a dry.
Yeah, that's true. But do you use heparin in
No,
everything?
no,
Because
it is
we
only-
don't use
It is
usually.
only flushing of the needle.
For liver biopsy, we need a length also. We do not want to. We do
Don't
not
want
want
fragmentation.
fragmented tissue.
Yeah,
For
true.
other biopsies, we need cells and just connected tissue. So it's okay.
Any other questions? I think we.
Yes, I think I do, want to just add one thing, as Dr. Arka rightly said. Before attempting this US liver biopsy, and next we will be coming to the treatment of the liver tumors, one should be very familiar with how to delineate the liver anatomy by linear endoscopic ultrasound, by segment. So there are literature also available. One should be very familiar before attempting these interventions.
You should be very good in diagnostic US at least before, and a little bit of.
Dr. Arka, do you avoid the extra hepatic portal vein for getting the portal pressures? Do you,
Yes, we don't puncture the extrahepatic portal at all.
Excuse me, sir.
Sir, one question. Sir,
Hello?
this US guided PPG.
Sir, one question is there. It was a beautiful lecture to hear from you. There is one question that what are the indications that we need to take liver biopsy from both the lobes? So it is one of the benefit of US guided liver biopsy over the percutaneous one.
Sometimes when we are writing papers, we need to make out benefits. Come up with benefits to write in the procedure. I don't think bilobar biopsies in clinical practice is practically needed.
No.
I mean, you can keep on going with saying that biopsy may not represent the whole of the liver. Some of your pathologies could be patchy, blah blah blah. You can keep on going, but I don't think anybody does bilobar biopsies in.
So sometimes in donors we get bilobar
some-
biopsy where there is doubt of significant stenosis, and it is a wrong notion that percutaneous cannot target both lobes. Of course, percutaneous can target both lobes.
I think the only time we have done percutaneous biopsy is sometimes we have taken it in a cirrhotic patient. The left lobe is not very good, and we have taken the biopsy and we find that it's very, very morphologically inadequate. Immediately you find, and so you think, chalo, right lobe se le. That is the only. Otherwise, I don't really think.
Thank you.
Please
Sir,
turn my slides on.
sir, can US guided PPG useful in non-cirrhotic portal hypertension or portal vein thrombosis?
So this is one of the advantages over HVPG, that the PPG will be elevated in even in non-cirrhotic causes, non-sinusoidal causes of portal hypertension. Also, it's going to be elevated. This is one of the advantages. So recently, we have had one of these patients. His LSM was again CKD and stage renal disease. His LSM was kind of on the upper range of normal, but he had varices and things were going on. Sometimes LSM was coming anything. So he basically had NCPF, PSVD with CSPH. So we were able to clear it.
Thank you, sir.
My slides. I discuss in brief applications of EUS in liver transplantation. So malignant lymph nodes in HCC, because if lymph nodes are malignant, then it becomes contraindication for liver transplantation. We see a malignant node here, round, hypoechoic, more than 1 centimeter in size. We can easily say it is malignant, but most of the time we don't get such lymph nodes. So this is an example of peripancreatic lymph node, a lymph node near hepatic artery. This is 14 millimeters. So this is subcentimetric, approximately 1 centimeter in size, again subcentimetric. So this is benign, rest are malignant. In our experience, most of lymph nodes in patients with HCC are actually reactive. We can see a difficult anatomic location, upper surface of liver, and this is right atrium. 8 millimeter at short axis lymph node, but because we are very close to our targets in EUS, so even this small lymph node near right atrium can be punctured easily and safely. It was malignant. Sometimes we see this type of image when we discuss these cases in pre-transplant presentation. HCC in left lobe and planes with stomach is not clear. HCC here and again plane are not clear. In radial US, we can say gastric wall infiltration. In linear US, we can say gastric wall infiltration. It is very rare. In several years, we had these two cases only. Post-transplant collections, we right lobe of liver in recipient, collection here and stomach. So this is retrogastric. IR need to puncture this through and through stomach to reach air. Again, a retrogastric collection, a very high up collection in relation to heart. For EUS, it is very easy. It doesn't matter it is retrogastric because we just puncture one wall. So one of these collections is this. It is like standard FNA4S. It is not difficult. But we cannot place stents. These are not WN or pseudocyst with a pseudo wall. So we just provide diagnostic puncture and we don't place stents. Multiloculated collection, again procedure remains similar. Uh, Almost complete aspiration is done in such cases. A thick collection, it was abscess actually. Sometimes we can make a diagnosis on table, but always we send for biochemistries. So we see it is purulent here and it is dark green. It was biloma. Same happens with donor collections because bowel comes in between in place of right lobe. So these donor collections and cut surface, they are difficult to get drained by IR, but they touch duodenal bulb. It is also rare, but both these cases we did complete aspiration from duodenal bulb and we did not require IR. Thank you. Any questions related to these procedures?
any questions, I think this is okay.
Okay, it's just one small we will show, and then basically you can also do a lot of loco-regional therapy. I mean, you can do whatever you want for the liver if it is accessible. So this is a liver as well. Sometimes what happens if it is close to the hilum, or if it's close to the caudate lobe, or if it is close to the diaphragm, it's a multidisciplinary thing. So it's a discussion with the radiologist. If the radiologist feels that it would be better to access it US guided, then you can always do it US guided. So for instance, this is a segment 4B lesion. You can see that it's arising, and it's actually going to, you will see it will come very close to the portal vein. And it was felt, there's a very it's an exophytic lesion very close to the portal vein, a thermal modality, but it's a small lesion, would not be very good. You can almost see it looks like a periportal lymph node actually from some of the places, but you can see that this here you can see that it's arising from, and it's an exophytic lesion. And then this was confirmed on contrast US. So as soon as you inject the contrast, you will find that there is immediate filling up. So within 10 seconds, you find that there is immediate enhancement inside the lesion, whereas the liver part is not enhancing. And then as you go on, this is almost completely washed out. After that, you can easily puncture the needle, and if the patient is affording, you can do an US guided RFA, or in this case, as it was not an affording patient, we did US guided alcohol ablation. So for a small tumor, you can go ahead and do that, and as you inject the alcohol, the bubbles will begin to appear, and in the end, you can also confirm by another contrast enhanced US to see what is the status. So there are many things that we can do with US, but I think at the end of the day, it is a multidisciplinary thing. It's not what you can do, but what is best for the patient, depending upon the approach that is to be used. Thank you. I think we will not discuss ETSO and all these things any further because we are running short of time.
I think we had a very good discussion on this morning workshop on endohepatology. So on behalf of my co-chairperson and myself, I would like to thank Dr. Narendra Chaudhary and Dr. Arkade for their excellent presentations, which are not only informative but also insightful. And I would also like to thank the audience for their active participation. Thank you.
Thank you.
Over to the organizers.